So my good friend Dr. Jin Shin asked us to explain why myasthenia gravis can produce either unilateral or bilateral ptosis or ophthalmoplegia. And the reason he's asking it is myasthenia gravis is a systemic disorder that is characterized by anti-acetylcholine receptor antibodies, and so it would be expected to be bilateral. However, sometimes it's just one eye, just unilateral ptosis or unilateral ophthalmoplegia, and that means it can mimic any pattern of pupil-spared, painless ophthalmoplegia or ptosis, whether that's unilateral, bilateral, or bilateral but asymmetric. And the reason is the levator palpebra superioris and the extraocular muscles are slightly different than the rest of the skeletal muscle elsewhere in your body. First of all, they have a different proportion of fibers, and they have a different type of fiber because they're being asked to do things very quickly. So their twitch, their kinetics is got to be way faster than your arms and legs. In addition, the levator that never takes a rest break. So there's constant tonic innervation to your lids to keep them open, and you have to stay like that your whole day. So when you're blinking, that is orbicularis, blinking, but the levator, he don't get no rest. And the extraocular muscles also don't get any rest. Even at night, you have rapid eye movements during your sleep. And so these two guys are going to be more likely to feel the effect of myasthenia gravis. In addition, because the two things are bilateral and symmetric, any change will be noticed right away. So if you have a little bit of asymmetry of your right bicep versus your left bicep, maybe 5 or 10%, you will not notice a 10% difference between your right and left bicep. But you'll notice immediately a 10% difference between the right medial rectus muscle and the left because you'll get diplopia. And you'll notice right away the levator because your lids will be asymmetric. And so to me, those two findings by themselves are enough to explain asymmetric or frankly unilateral findings. Proportion, type, and lack of rest. There's chronic tonic innervation to the levator. But there's this other thing that you need to know about myasthenia, which is it's variable and fatigable. And so the anti-acetylcholine receptor antibodies probably aren't going up and down. That's probably not why it's changing. What's changing is a differential threshold effect. So you have the acetylcholine and the lack thereof because of the binding antibody or the modulating antibody has an effect that's only manifest at a certain threshold. And so it's only when you're really, really tired or at the end of the day, then the lid drops. It's not really that at the end of the day, the acetylcholine antibody is getting more. It's a reserve and release problem. So the amount of reserve and the amount of acetylcholine released at the levator and the extraocular muscles, the reserve is low and the release is small. And so any disruption in a low reserve, low release system is going to cause fluctuation that will cause a threshold effect, and that produces the symptom of variability and fatigability. So in answer to Jin's question, how can myasthenia, a systemic antibody in your blood, produce unilateral or markedly asymmetric and bilateral ptosis and ophthalmoplegia and no generalized symptoms? And the answer is different muscle type, different muscle proportion, different muscle kinetics, no rest, and the variable and fatigable nature is different reserve of acetylcholine and different release kinetics of acetylcholine, making this particular muscle, the levator, and the extraocular muscles more susceptible to the disorder we call ocular myasthenia gravis.